Good afternoon. My name is Michael Shankle, and I am the Senior Director of Capacity Building at HealthHIV, a national nonprofit based in Washington, D.C. And I'd like to welcome you to this Research Plenary 2, Interconnectedness Matters. Today we have a wonderful panel of faculty who will be presenting with us today that I would like to take the opportunity to introduce them to you today. If you do not already know some of these dynamic speakers. Today's session will run until 3:50, and after our speakers are finished their presentations, each of them will present between 15 and 20 minutes. And we will take questions at the end of the session today. You can feel free to use either the chat box or the Q&A box to ask those questions today. I'd like to start by welcoming Dr. Gail E. Wyatt, a clinical psychologist. A clinical psychologist is a board-certified sex therapist and professor of psychiatry and behavioral sciences at the Jane and Terry Simmel Institute for Neuroscience and Behavior at UCLA. She directs the Center for Culture, Trauma, and Mental Health Disparities and the Sexual Health Programs. Dr. Wyatt has published well over 250 publications, written 6 books, and has provided congressional testimony 10 times. Stolen Women, Reclaiming Our Sexuality, Taking Back Our Lives by Willie and Sons is a bestseller that details the effects of slavery and oppression on African American women today. Dr. Wyatt guest edited the May 2017 issue of Psychological Trauma, Theory, Research, Policy, and Planning, including research conducted by first authored South Africans of color. She and her team just completed an implementation study of the culturally congruent CDC-endorsed EBAN intervention for HIV serodiscordant couples. The intervention has been successfully adapted for South African couples. She and Dr. Harlan Blocher co-edited a special issue of Mentoring Students of Diversity Backgrounds in the 2019 issue of the Journal of Orthopsychiatry. Dr. Wyatt and her team also have 1 NIDA-funded domestic and 2 NIH training grants include implementation science. Her multidisciplinary team is currently using the UCLA Life Adversities Screener to implement Healing Our Hearts, Minds, and Bodies, funded by NHLBI to reduce cardiovascular and trauma risks for HIV-positive people of color. Other projects include a Gilead Science-funded intervention for HIV-negative women of color, and a Cal Wellness Foundation funded a women-centered intervention to reduce HIV, STI, and reproductive health risks for women of color in Los Angeles County. In 2016, she received the Chancellor Award for Diversity and Inclusion. In 2017, she received the Lifetime Achievement Award of the American Psychological Association for her work on the effects of trauma on mental health. In 2019, she was made an honorary professor at the University of Cape Town, South Africa, for research and mentoring, and she guest edited a special issue on African American women and HIV in ethnicity and disease in 2020. She has been married to Dr. Lewis Wyatt for 55 years, has a son, 2 granddaughters, and a daughter who is an angel. Dr. Janet Turan is a professor in the Department of Health and Policy at the University of Alabama, Birmingham School of Public Health, director of the UAB Sparkman Center for Global Health, and the director of the Behavioral and Community Sciences Core of the UAB Center for AIDS Research, CFAR. She is a social and behavioral scientist with extensive experience in public health research, health behavior, sexual and reproductive health, and qualitative and mixed methods research methodologies. Dr. Turan's current research includes qualitative, quantitative, and mixed method studies designed to address HIV-related stigma, as well as intersectional stigma related to poverty, gender, race, ethnicity, sexual orientation, substance use, and reproductive choices in settings as diverse as rural Kenya and the Deep South in the United States. Circe J. Gray LeCompte has over 2 decades of professional and academic experience in the United States and abroad, and holds a Master's of Science and Doctor of Science in the field of social and behavioral sciences from Harvard University, Harvard T.H. Chan School of Public Health. Her research over the past decade has focused on the development and evaluation of cutting-edge interventions to promote sexual health among underserved LGBTQ persons and youth of color in particular. For her doctoral dissertation, she leveraged qualitative and quantitative approaches to better understand the conceptualization and implementation of serial adaptation among Black men who have sex with men in the United States. During her academic tenure at Harvard, she served as a teaching assistant for 20 graduate level classes and received a teaching assistantship graduation award in 2020. LeCompte currently serves as the Director of Health Services Research and Evaluation and Health HIV, and is a postdoctoral research fellow at Rutgers University Cancer Institute of New Jersey. She is also the editor-in-chief of the Harvard Public Health Review. As you can see, our speakers today have very extensive backgrounds, and I'd like to again welcome you to our session and turn it over to Dr. Wyatt.
Thank you very much, Michael, and thank you to the other presenters. It's very nice to share this hour and so with you. I'd like to show you a little bit about some of the research that we are currently completing, and so I'd like to show my slides now. Howard University is very dear to me, and I was very happy to see that they were supporting this conference. My children, Lance and Lacey Wyatt, attended Howard and both became physicians, graduating from the UCLA School of Medicine, and went on to other wonderful careers. This particular paper has to do with couples, serodiscordant couples, and I'd like to share some of our findings with you. I wanted to also thank Allison Hamilton, who is co-director of my Center for Culture, Trauma, and Mental Health Disparities, for her assistance in creating these slides. Next slide, please. Next slide. Next slide. Not sure how to make the person know that oh, there we go, okay. First of all, African Americans are disproportionately affected by HIV and AIDS. For almost 40 years, we have known this. Heterosexual exposure is extremely important to examine. It is the most common mode of transmission in the world, and it's also most common in women and second most common among men. in some communities, being HIV positive and the whole idea of living with a chronic disease is becoming more normalized, but that's not necessarily true amongst African American communities. So that there is quite a lot of stigma to this day in either being HIV positive or being in a relationship where your partner or you are HIV positive and your partner may be negative. So serodiscordant couples, one where the one person is positive and the other is negative, these couples are often ostracized by communities, churches, families, all sorts of very negative accusatory statements are made. And usually the encouragement for the negative partner to leave the positive partner that, quote, they can, quote, do better, unquote, by finding another person to be with. That's not what we found when we looked at serodiscordant couples, particularly amongst African Americans. Next slide, please. In HIV, we tend to be very siloed in terms of treating an individual and not couples. So many times the HIV negative person who may go to the appointment with their positive partner has nothing to do. And that's very unfortunate. This is an opportunity missed, I feel, in the African American communities where HIV clinics may be located, or in any HIV clinic for that matter, that there should be some kind of educational program going on for the negative person as well as the positive person, because both have a responsibility for protecting themselves and each other. And yet we need more services that are broader than just for either the negative or either the positive. Couples are an important dynamic to look at, and particularly in amongst African Americans, but most of the couples-based interventions have been treated and tested in Africa, not in the United States. So we know very little about community-based settings that may lend themselves better to working with African American couples and not just individuals. There are behavioral science programs related to condom use that mention very practical approaches to reducing sexual risks and STI risks. Both are very important, but we need to know more about them. So there's really very little information, not only about these interventions that may be more appropriate for couples, but the cultural context of African Americans that can facilitate behavior change are hardly ever discussed, as if that is okay. It is not. It's a huge reason why I think many people are very disappointed with the findings, the behavioral findings related to people who are at risk for or living with HIV. When the cultural context is not observed, we're simply talking about teaching people different information, but that doesn't necessarily mean that information is going to be well received. I have found that in my research, interconnectedness is extremely important in understanding how people choose partners, why they stay with those partners, and maybe why they don't use the kind of barrier methods that they should. Next slide, please. There are two factors that I wanted to focus on today. One is poverty. We talk a lot about poverty, an individual being poor or having poor or limited resources, but there are many ways to look even deeper into poverty and just how few resources an individual has. So we focused on couples that were self-identified as poor, but looked at just where they fell on the poverty line to understand what kind of resources they did not even have access to. And we saw that the level of poverty really has an even more significant impact on the couple's ability to garner the resources that they need, not only in unstable housing, food insufficiency and lack of transportation, but also not even having an awareness of the kinds of other resources that might be available to them. And then secondly, mental illness. Mental illness is not well understood in ethnic communities because it has such a negative stigma. When a person reveals that they have a diagnosable mental health problem, usually they can also be stigmatized and be ostracized in the community. So the intersectionality of poverty, mental illness, and serodiscordance among couples is what this paper is really all about. Next slide, please. So the ABAN program is a program developed about 15 years ago for serodiscordant African-American couples. It was funded by the National Institute of Mental Health, one of the very few studies where 3 out of the 4 sites were led by African-American investigators. This only represents how few opportunities African-Americans have to conduct and to lead research that has some relevance to African-Americans. And I think it's particularly important to focus on issues like stigma, because the lived experience is hardly ever discussed. When we look at the people who are doing the work in HIV and AIDS, hardly any of them are African Americans. And I think that's an opportunity lost, and it has not really increased in terms of opportunities. And here we are 40 years into this illness. But the ABAN program tested the efficacy by looking at a cluster randomized controlled trial in 4 US cities, New York, Atlanta, Philadelphia, and Los Angeles, where I led my team. We had 8 sessions that were culturally congruent. They reduced the risks amongst these African-American couples who volunteered to participate and were reimbursed for their time and their effort. This was a hybrid type 2 study design in that we not only looked to see if couples changed their behavior, but we also looked at the clinics in which they were referred or where they received care, at least for the positive person, to see how they managed when these couples were involved in this clinical trial. Next slide, please. So just a little bit about the ABAN project. It had cultural components. We used Nguzo Saba. We used ethnic music that many of the couples had selected for each of the sessions. Music is a very effective way of creating a mood in these sessions, and also in encouraging behavior change or helping people to acknowledge that the behaviors that they have a great deal of difficulty in changing. Also in poetry written by African Americans. So we use the eyes, we use the sense, the mood in order to help couples to grow. And they were in groups of maybe 5 or 6 couples per session. Interconnectedness came out in the sense that many couples felt very emotionally connected to each other, but also economically connected. One person might have had housing, the other one might have had food stamps. And so that way, their relationship was instrumental. If the romance came along, that was a second, but many times these couples just needed to survive. So certainly you had to bring something to the table if you had a long-term relationship. We delivered the intervention using African-American males and females in a dyad. They were not in a relationship, but both were able to role model for the couples how they communicated, how they had to compromise on certain issues, particularly involving the use of some kind of barrier method to prevent unwanted outcomes. They learned about empowerment, communicating their wants, not only in sex, but also just in the relationship in general, contraception, birth control, or any other matters that were important to couples to communicate. Their conversations were much richer and much more illustrative of individuals who wanted to take the time to get to know each other even better, and they learned how to communicate without arguing, yelling, and screaming, or being physically violent. In our discussions, we also talked at length about STI awareness. We know that STIs can be a precursor to HIV infection, and so couples had to get STI tested as well as HIV tested at the beginning and the end of the study. Next slide, please. So we did quantitative as well as qualitative data, and these are just some examples of what kinds of issues that we discussed in many papers that have come out about the very interesting findings. But I wanted to go on to the next slide and to show you some findings that I found particularly interesting in regard to interconnectedness and staying in an intervention. Next slide, please. We created a critical vulnerability score that helped us to better understand at what level these couples were, had very few resources in terms of being able to afford any kind of enjoyment in their lives. They were really at their survival level. These were couples that had very little education, much less than a high school education. They were unemployed. They had no money. They had very insecure food. They had unstable living situations, 2 or more dependents, even in spite of all of these barriers. They had histories of incarceration. As I said, one was HIV positive. Both tended to have histories of alcohol or substance use, low support to cope with ethnic discrimination, a history of interpersonal violence that could have occurred, but not in the last year, and or a history of child or adult sexual abuse. When all of these factors were added together for the critical vulnerability score, we also looked at how it affected the attendance in the sessions that we held and if the couples stayed together. Next slide, please. This is just a breakout of our consort chart to let you know what happened to the 156 people who were screened for the study that we're talking about today. 91 were enrolled, but as you can see on the side margins, there were a number of issues that came up that made a significant number of people drop out of the study. Only 52 in Los Angeles and 39 in Oakland finished the intervention. And we had all sorts of challenges, including death, that made it impossible for other couples to complete. Next slide, please. The quantitative results indicated that 92 individuals completed the baseline, but only 39 completed the post-test. So we based these findings that I'm reporting on, of course, the pre and the post data. 30 completed a 3-month follow-up. And most couples that either completed the intervention together or dropped out as couples. In other words, the couples stayed together. If they finished, they'd finish together. If they dropped out, they tended to drop out together. It may have been the wish of only one of the couple members, but because that person was dropping out or staying, it motivated the other person to drop out or stay. All women who completed the post-test had partners who also completed it. And all but one woman who completed the 3-month follow-up had partners who completed it. Condom use increased in the couples that were involved in the ABOND study from baseline to post-test and from baseline to 3-month follow-up. We were really excited about these findings because while we know that couples can use more than just condoms today, if they don't have some of the other antiretroviral medications at their use, if they haven't been to the doctor, or if they're not going to the doctor for some reason, if they're used to condoms and comfortable with them and they have them at hand, they're more likely to use them. So we found significant increases in condom use amongst these couples and no seroconversions from the baseline to the 3-month follow-up. Next slide, please. So higher critical vulnerability scores were significantly related to depression at baseline and from baseline to the 3-month follow-up. This is a measure of how poverty can affect the ability of couples to learn and to benefit from an intervention. And then more of those who completed the 3-month follow-up had incomes above the poverty line than those who dropped out. So again, economic resources can have an impact on finishing an intervention and benefiting from what they learned. Next slide, please. The qualitative results were equally as interesting. And while I won't have an opportunity to read all of these for you, I'll read the second one. For the negative person, it really impacted him. This is a woman who's positive talking about her partner. It really did. He became more conscious of stuff. He became more conscious of his health. Really, it was good, okay? He became more conscious of seeing things through somebody else's perspective. Even though he had a medical, technical background, he was very uneducated as far as STIs. So it made him exercise that part of his intellect. Next slide, please. And then I'm going to read this one too. I enjoyed the study. It had a lot of cultural stuff in it. It had a lot of the concept of Iban, the unity, the mojo. I really like that. The collectiveness. I can't think of how you say that. I enjoyed it. And I enjoyed the presenters. For the person who's never dealt with HIV, it was very informative, very open-minded, because some of the things that normally a person that doesn't have it, they're speaking of HIV, wouldn't think about that way, another person who has it thinks. It would all stigmatize that person or label them a little bit. So it breaks down a lot of that. We were really encouraged by this very positive endorsement of the intervention. It's very important not only to keep couples in something of value, but something that they learn from. Next slide, please. PrEP was an option for these couples. So many of them were on PrEP and also using condoms. So the conclusions of the study. Intervention was effective in increasing the overall condom use and 100% condom use at post-test all the way to the 3-month follow-up. However, the attrition in this study was high. These were couples with very few economic resources. Most of these couples would probably have been dropped by the interventionists, not allowing them to drop, but dropping them because they had so few resources. And it was a real struggle for them to get to the sessions, to be on time. Many times they were hungry and we fed them a full meal before the intervention started, just so they'd have the energy to listen. But they had challenges with housing, food, transportation, and just maintaining their risk reduction strategies. We gave them condoms, female and male, to have as many as we could garner so that they would always be able to stockpile these and have them when they needed them. Retention was higher among those with less economic vulnerability. Next slide, please. So in addressing these couples' needs, this is not an issue that's standard, and we want to encourage our listeners to really consider offering services to positive and negative individuals who have a relationship. The negative partners may not be talking about risk reduction with someone at the time. There are other things that they could do, but that doesn't mean they'll be interested. Many negative partners told us when they started, they really didn't need this intervention because they were in a loving relationship and they knew that they could trust their partners. But in going through the intervention, they learned each individual should be protecting themselves from giving their partner something and protecting themselves from getting something from their partners. If both people do that, then you don't have to worry so much about having to blindly trust a partner to do the kinds of things that they need to do to lessen the likelihood of transmission. The negative partners, however, were more likely to have partners outside of the positive relationship. And that was mainly because some of the positive individuals were very ill for long periods of time. And so the negative partners developed other relationships. Some, of course, did that anyway. That was just kind of like their MO. And so we had to talk to them about condom use outside of the relationship at least, as well as condom use inside. But the couples had so many strengths. And this is where I feel people miss the importance of being and looking at relationships and allowing that relationship to thrive while in an intervention. Pardon me, the positive partner was really buffered by the relationship and many times encouraged to use their medication because their negative partner would remind them to take the medication just on time and whatever. When they stayed together, they also learned how to reduce transmission skills, as I mentioned before, and to increase communication. So they not only learned how to just talk to each other in respectful and loving ways, but they also learned how to disagree and without yelling and screaming and harming each other. That was very important. Adherence was more likely in couples who stayed together. The burden of poverty, though terrible and shouldn't be experienced by anyone in a rich society like America, but it was shared by someone else, which meant in many couples it was easier to bear. Learning to use condoms and how to communicate about them really strengthened the bond of many couples. Next slide, please. And so I want to take the words of Maya Angelou: do the best you can until you know better. Then when you know better, do better. And that's exactly what we saw in these couples. For those couples who could maintain a stability in their lives long enough to finish this intervention, they learned a tremendous amount. We have some key takeaways. Communities and families within communities need education about what it means to live with a chronic disease. There are many chronic diseases within African-American communities, but many people are not learning how to live with them, not just being stable, just being labeled as having them, but also learning how to live positively with them. Being HIV positive, being ill or sick used to be a sign of weakness. It is not a sign of weakness. Many times it's a sign of courage to go on living with dignity and with love for those people who are fortunate enough to develop a meaningful relationship. And the value of being interconnectedness actually amongst African Americans is the factor that has kept us alive for all these 401 years. It certainly is still alive and living in the serodiscordant couples that we had in this study. It confirms the bond and it helped to increase the health of the couples. And with that, last slide, please. I want to thank you very much for listening, and thank you for this opportunity to the team, to those team members, and to NIMH that has always been for me all 47 years of my career where I've been continuously funded. Thank you very much.
Thank you so very much, Dr. Wyatt. That was totally fantastic. I just want to remind folks please, if you have questions for Dr. Wyatt or throughout the presentation today, if you could just put those either in the chat box or the Q&A feature, and we'll get to those at the end of the session. And now we'll turn it over to Dr. Turan.
Thank you so much. That was a real pleasure to listen to that presentation, and hopefully this one will complement it. Here, I'm going to take a kind of a broader look at what we know about intersectional stigma and HIV-related health, and think about how we can try to embrace and understand some of the complexity that this involves. So I just want to remind us about how stigma can affect health. Sometimes it seems like an abstract concept, but we know from a lot of research over the years that stigma adversely affects the quality of life and the physical and mental health of people who are living with stigmatized conditions. We also know that stigma, and especially anticipations or fears of stigma, make people less likely to practice preventive health behaviors or utilize health services that they really need. And in fact, stigma can also lead to a lot of overt acts of discrimination and violence, which of course have adverse consequences for health. So I just wanted to share a framework that our team has come up with to try to understand how HIV-related stigma affects health, and also the role of intersectional stigmas around race, class, gender, sexuality, and other parts of our identities. So we know that there are different dimensions of stigma. It can be actual experiences of abuse. It can be perceptions of stigma out there in the community. It can be fears and anticipated stigma. And then internalized stigma has also been shown to be a real determinant of people's mental and physical health. So, and these work through interpersonal factors like social support. They also influence your psychological resources like your self-efficacy, your mental health, and importantly, stress. And so according to this framework, these factors can both directly affect your HIV-related health, or they may affect your engagement in HIV care behaviors. So we just wanted to give this as an overall framing. But what I really want to focus on today is intersectional stigma. And so we know that people have a lot of different parts of their identity, and people are whole people, and we need to, that's what I talk about embracing the complexity, is that we need to realize that people have different parts of their identities, And in some cases, those identities they may have multiple stigmatized identities in some societies, and may experience different types of stigma and discrimination around those identities. So, for example, a woman who's pregnant and living with HIV might be experiencing HIV-related stigma. She may be experiencing stigma and discrimination because she's in a certain racial or ethnic group. She may be stigmatized because she's poor, or if she's pregnant and living with HIV, there's a special stigma around that. So this is a complex situation that a lot of people are living with. So when we talk about intersectional stigma, we're talking about the convergence of multiple stigmatized identities within a person or a group, and we're trying to understand those and also address their effects. And this helps us to think a bit more holistically about how this experience influences people's behaviors and their health outcomes. And importantly, I just want to emphasize that this perspective highlights also protective factors like social support, resistance, and adaptive coping that can happen when people with similar identities unite and come together. So it's also, we're looking at the vulnerabilities, but we're also thinking about the strengths that can come through intersectionality. And so this is obviously not a new concept. Individuals as far back as Sojourner Truth characterize the experiences of being a Black woman in societies that devalue both female gender and minority racial status. The term intersectionality is largely attributed to Crenshaw's work in 1989. So a lot of this came out of the Black feminist perspective. But now we're using this lens of intersectionality to look at stigma. And so recently, NIH, the Office of AIDS Research, and NIMH sponsored a great workshop, really important contributions from academics and community members and other partners talking about intersectional stigma. And so I was a part of a great working group, and this was sort of some of our definitions that came up to talk about what is intersectional stigma. So really it's a pretty broad definition where we're looking at the juncture of multiple stigmatized identities, and those can be in some different categories. So we might be talking about people who have one or more coexisting health conditions, like living with both HIV and mental illness, or mental illness and substance use disorder. We're also talking about sociodemographic characteristics that race, ethnicity, gender, sexual orientation, immigration status, that can be stigmatized in many societies. And we're also talking about intersection with behaviors like substance use and sex work. And so we really want to center the experiences of these people who are facing multiple discriminating forces and try to elucidate and understand their experiences so that we can try to support them. So with that framing, I will talk a little bit from a research point of view. How do we study intersectional stigma? It's extremely complex, obviously, and so people are using purely qualitative research approaches where you really try to understand in depth the intersectional experiences of people. Others are trying to study it quantitatively and try to understand, with questionnaires and other measures, how people's different experiences of intersectionality combine to influence their behaviors and their outcomes. And then, of course, mixed methods research, where we bring together the strengths of both qualitative and quantitative research, I think can probably give us the richest, most holistic understanding. So I just wanted to talk a little bit about what we know from the literature so far about intersectional stigma. It's a growing field. There's a lot of interest in this kind of approach. And so generally when some studies, they use vignettes. And so they try to see how people's attitude sort of person might change depending on, you know, that person's constellation of stigmatized identities. And so in that case, I'll go back there, you often find that people want to social distance more from someone when they have a combination of identities. So someone who's living with HIV, but is also described as a substance user, people would want to have more social distance from that person. It's not always that easy and additive, but in general, those kind of intersections are seen in the literature. And in general, when people talk about living with more than one stigmatized identity, they seem to have exacerbated more experiences of stigma. But there actually are some studies that have found out when you're living with one stigmatized characteristic, you may actually have less stigma related to another characteristic. So again, it's a qualitatively different experience and not so simple. In general, most research has shown that people who are living and experiencing a variety of intersectional stigma would have worse, less adherence to HIV-related health behaviors and worse outcomes. So some of the research that's come up recently, and again, this has using different approaches. So the first one is an article by Quinn and colleagues, The Fear of Being Black plus the Fear of Being Gay. And this is the qualitative approach. And they found that these participants' perspectives on PrEP were very much shaped by their intersecting experiences with racism and homonegativity. So you can't look at these in isolation. Here's by Dr. Logie and colleagues, another study looking at intersectional stigma and HIV-related health in women living with HIV in Canada. And this was a quantitative approach where they used, detailed questionnaires and quantitative measures, and then used structural equation modeling to try to look at pathways. And they found that there was a stress related to living with intersectional stigma that, along with lack of access to support system, was contributing to increased depression in this group of women. And in turn, that kind of depression and mental health challenges was negatively influencing their coping and was compromising ART adherence and their HIV-related health outcomes. Another study by Earnshaw was interesting because it was a longitudinal study. And so they found that people who reported that they felt internalized stigma around race and sexual orientation before they were diagnosed with HIV had greater internalized stigma around HIV after being diagnosed. So there's definitely an interplay of these intersectional stigmas and their effects. And I will point out that there's less research on the resilience factors and the strengths and the solidarities around intersectionality. That's something that we're working with colleagues on a review to see what there is out there and try to stimulate more research on those topics. So now I want to just talk briefly about one study that we've done here in the US with women living with HIV to start to look at intersectionality, some of the intersectional stigmas that women are living with. And so this is a study funded by NIMH. We call it the WAVE study. And we're looking at mechanisms and longitudinal effects of stigma. And this is the Women's Interagency HIV study, the WISE study, which people may be familiar with. It's a large cohort of women living with HIV that's been going on since 1994 with new new waves of recruitment, some along the way, including adding of sites in the US South in 2013. And this is a study that is majority of women in the cohort are Black and Latina women of color. And it's been going on for quite a while, as I mentioned, and it has now actually merged with a cohort of men, which people may know, but this study is based on the women. So I'm not going to go through the whole, the aims of the study, but the third aim of our study was to examine the link between intersectional stigma, and we were interested specifically in stigma around HIV, race, ethnicity, poverty, and gender, and how that affects women's adherence to HIV treatment recommendations. And we were able to use mixed methods research. So our methods included qualitative in-depth interviews with women living with HIV across different sites across the cohort, as well as questionnaires that included validated measures of these different stigmas that we were examining. And so here you see Dr. Whitney Rice, who led the qualitative part of this study, and which is, we've published the qualitative findings so far in Social Science and Medicine. But I wanted to give you just a little taste to some of those findings. And I think this, I like this quote because it really sort of brings out the complexity and difficulty of disentangling and understanding intersectional stigma. So this woman is saying, all my life, I've always wondered what people discriminated against me for. Is it because I was Black? Is it because I was biracial? I never knew if people discriminated against me because I was HIV positive, because I was a woman. Honestly, I don't know what. I can't really pinpoint. I just know that something, I guess it's like a gut feeling, something just didn't feel right. Like somebody insulted me and later I'm like, what was that for? So it's even a challenge in qualitative research because people, it's hard for people to separate it out, and it's not something that you can separate out. You're a whole person with these aspects of your identity. But we did discover in this study that women, women they did talk a lot about stigma they experienced because being a woman living with HIV. They talked about stigma discrimination around race, and importantly around being in mixed race relationships. They talked about stigma they experienced because they were poor, but they also talked about stigma around incarceration histories, age, and weight and body size. So a lot to unpack there. Now, our quantitative analysis for this study are using latent class analysis, where we measure these types of stigma separately and then try to see how they hang together and people are in sort of different groups or profiles. So we have the people who report low discrimination on all these, on poverty, gender, HIV, and race. And these are enacted, experienced stigma or discrimination. We have people that have reporting high discrimination on all these categories. We have some that just report some gender and race, some report a combination of poverty and HIV, and some people that have high poverty, gender, and HIV discrimination, but report low racial discrimination. So we've got a mix of profiles here, and when you do look at these profiles, you see that they are related to their HIV adherence, their visit adherence, and their viral load and other outcomes in different ways. I mean, the people who are high on all have, in many ways, the worst outcomes, but the ones in between have some nuances as well. So we're still working on these data, but I think it's an interesting way to look at it. So I just did point out that there are intervention approaches that are trying to address intersectional stigma. And we often focus on the healthcare setting because that's a place where we can influence behavior, and we know how impactful it is for people who are living with stigma. To be stigmatized in a healthcare setting is really damaging. So there are interventions that work with health workers, medical students, nursing students, whole facility approaches, different ways of interacting with those clients. There are also interventions that work directly with people living with HIV or community members to try to address intersectional stigma. And these can be both group-based and individual interventions. And then there's some interventions that work with both health workers and clients together to try to increase contact and build empathy and support among healthcare workers, as well as empowering clients. So what's the way forward for intersectional stigma research? And this was these are the conclusions of a working group that was sponsored by the NIH Fogarty Center looking at stigma and global health. And we had a working group that focused on intersectional stigma. So we believe that we still need to develop more nuanced quantitative measures of intersectional stigma, but we also need to develop good interview and focus group guides that we can share as a community because it's hard to ask about these questions and to get people to open up in a way that's really going to allow us to understand. We think we can look at parallel measures of common elements. We still need to look at how the impact of stigma on health varies for different health conditions, and look at how stigma related to one characteristic might change in the presence of another characteristics. We still need to understand the drivers of stigma and the mechanisms for impacts on health, and importantly, identify the pathways that are amenable to change. In terms of interventions, I really believe that we need to develop strategies that address these unique barriers, but they also capitalize on that solidarity and social support of shared identity. And I think Dr. Wyatt's intervention is a nice example of that. We need to identify which types of stigma are best addressed simultaneously in interventions. There are some stigmas that often go together, and can we address them together simultaneously, again, to me, recognizing the whole person. And we need to derive strategies to meaningfully engage individuals affected by these stigmas in the development of these interventions. And the policymakers, we hope the funders will prioritize intersectional approaches and see that that's going to maximize the impact of their investments. We want them to prioritize intersectional approaches. And we all have to work together to break down silos and really work in interdisciplinary teams. So those are some of our recommendations. I want to acknowledge the big WAVE study team, which has investigators and collaborators at different sites around the country. I want to acknowledge the support of both NIH Fogarty, OIR, and NIMH in supporting a lot of this work. And these are many of the co-authors and working group leaders. And just even though this is an old UNAIDS slogan, I still think it's what we have to be striving for. Zero new HIV infections, zero discrimination, zero AIDS-related deaths. So thank you very much.
Thank you so much, Dr. Turan. That was also terrific. And just reminding people, feel free to drop some of those questions that you may have in the chat box or the Q&A feature that we'll take at the end. And now we'll turn it over to Dr. LeComte.
Hello, everybody. I'm just going to share my slides here. Oh, somehow we got. Well, hello. Thank you so much for having me today and for allowing me to share my presentation with you, especially on such a panel with such esteemed members and incredible presentations. I am much obliged, so thank you. My presentation today is called This Used to Be Chocolate City, Gentrification and Social Geography Among Black Men Who Have Sex with Men in Washington, D.C. I know that's quite a title, but coming from academia, that's actually quite short. So I don't have any conflicts of interest and I don't list them here, but my dissertation committee was instrumental in making this project a reality. And just want to thank them today. This study that I'm talking about in particular was part of a larger work of research called the Photo Use Study, through which qualitative research was collected and then informed, that also informed a qualitative study after that. This type of study is called an exploratory sequential multiple method study. And it overall was about addressing how Black men who have sex with men engage in seroadaptation. Seroadaptation is a very fancy way of referring to sexual harm reduction. And as any good research project does, once I started getting into it, the idea that I would be focusing on seroadaptation kind of went out the window because sexual harm reduction is an important part of the lives of Black men who have sex with men. However, I found that the population I was working with was very concerned with an overall approach to health that was informed by their formative experiences as well as their current lived ones, and particularly by the relationships that they had with each other. Black men who have sex with men depending on each other to navigate the world, support one another, and access health care. And really, it mitigating stigma. So just some terminology before I move on. Black and African American in my study were used interchangeably, but with the knowledge that, and also to refer to persons of Black descent overall living in the United States. However, it was acknowledged that these are not terms you should conflate. We also use Black men who have sex with men. The term is quite fraught. MSM is a term from the US CDC, Centers for Disease Control and Prevention, and it's meant to address behavior rather than orientation when it comes to sexual encounters. In this study, it encompassed all gay, bisexual, and questioning men, as well as trans women, and these were women who were identified as male at birth. Also, the term LGBTQIA+ was used throughout the study to encapsulate everyone who is listed there. So my research question that I'm talking about today is how has gentrification affected the lived environments that facilitate creation and maintenance of social support networks among BMSM in Washington, D.C.? The public health concern, of course, around that is HIV among BMSM. Now, this population lives at the intersection of two communities that have been disparately impacted by HIV since the epidemic began. BMSM today represent less than 1% of the population, yet account for about a quarter of the cases that occur each year. And young and BMSM and Black trans women are especially impacted. BMSM 13 to 34 alone represented about 3/4 of all new HIV cases that occurred in 2017. And anyone in the HIV arena knows that in 2015, the CDC announced that BMSM have a 1 in 2 lifetime chance of HIV infection, which is quite alarming when you consider the national lifetime chance of HIV infection is 1 in 99, and for white women, by contrast, is 1 in 508. Pick up any paper about Black men who have sex with men, you will read that they are hard to reach and they're underserved. Characterized by high poverty rates, housing and food instability, childhoods on average marked by abuse, leading to early school dropout, leaving quite vulnerable to early sexual debut, particularly with older partners, which creates a great deal of power dynamics. There's survival approaches, whether it's sex work, survival sex, drug use, can lead to early and ongoing engagement with the legal system as well, which creates a lot of problems for getting employment and living a full life and access to care. How does that intersect with gentrification? Now, gentrification, as everyone knows, because it's throughout the United States, refers to an intense and rapid economic and social investment in underdeveloped urban areas. And when I say underdeveloped, a lot of times it's not underdevelopment, it's just disinvestment by the local powers that be in certain areas. In Washington, D.C., because the disinvestment and power circumstances has been really impacted over the last over 20 years. More than 40% of the district in 2000 was earmarked as ready for gentrification. And has resulted in the displacement of about 20,000 African-American persons, or 6% of the Black population in Washington, D.C. in about 13 years. Of course, low income and older BMSM are more impacted than other MSM or LGBTQIA plus communities in Washington, D.C. to be impacted by gentrification. And as with all African-Americans in the district, VMSM are more likely to live in wards 7 and 8 of Washington, D.C., where life expectancy is about 15 years below the national average. So the study setting, of course, doing a study like we were doing, Washington, D.C. was the ideal place because it's historically African-American, and about 10% of the population as a whole is LGBTQI+. 27% of folks who identify as LGBTQA+ are African-American, and more than 1/2 of those are estimated to be BMSM, and 27% of all people with HIV in the district are BMSM, which aligns with the national average. I just wanted to show you some of the shifting demographics that have happened over the past 40 years in the district. As you can see, over all the way to the left, Washington, D.C. was predominantly Black in 1970, about 70% of the population, and that's indicated in the dark blue. When you reach 2015, you can see that the dark blue patches have dissipated and are primarily concentrated in wards 7 and 8. And if you look over to the far right, you'll see that the dark purple places, wards 7 and 8, show that the persons who are born in the district primarily live in wards 7 and 8 and are primarily African-American in the district. Now, one of the things about persons living in wards 7 and 8 is that Washington, D.C. is not equal in terms of its environmental scan, if you will. So wards 7 and 8 lack basic amenities, grocery stores, public transportation, and also access to care, which we'll see in just a moment. In terms of how that intersects with LGBTQIA+ populations, we see here again the maps in 1970 and 2015 of the that show the African-American population in dark concentrations of blue. You see that there's a great deal of dark concentration in most of the wards in 1970, as well as a large concentration of overlapping blue dots. These blue dots are actually LGBTQIA+ serving recreation areas and organizations, whether they're health organizations or advocacy outlets. You see that they crossed over into white and non-Black areas and also into Black areas. By 2015, you'll see that there's very few blue dots relative to 1970. And you also see that dissipation, again, that we saw on the other maps of the African-American communities predominantly being in wards 7 and 8. There are no identified dedicated LGBTQIA+ organizations in those areas. And in fact, most of them are actually in areas considered white. This has had a profound impact on HIV and healthcare access in the district for Blacks versus whites. So all the way over to the left, you can see that the map is quite similar. This is overall HIV incidence in Washington, DC, all the way to the left. Right next to it, to the right, is HIV incidence in DC among Blacks 2013 to 2017. You see that, that dark purple corresponds again with where African Americans predominantly live, farther to the southeast. It also corresponds with the percentage of persons living in poverty during the same time period. What is intriguing right here to the far right is the incidence, same time period of HIV among white persons. What you can see and what you can't see in the other maps quite as well is some blue and red dots. Most of them are concentrated in areas where white MSM live and work. There are not many of those red dots in Ward 7 and 8. In fact, you actually only see 3 red dots, which are Rhyme white HIV care providers in Ward 7 and 8, where most people living with HIV reside, with very limited transportation to get to those providers. The black dots are just HIV testing areas, and again, most of those are located in the other areas. So again, just to stress that this is a population with limited access to care, a great deal of HIV and comorbidities, and also a shrinking area where they live, and increasingly sort of fragmented existence, which we'll see in just one moment. As I assess the data from this study, I was guided by a theoretical lens. I won't go into detail in here because my colleagues were able to talk so eloquently about intersection, which I really appreciated. To collect data, we used some innovative, or what we thought was some innovative approaches to qualitative methods. We focused on only folks who were 18 and older, and we really went into those areas that were doing outreach to African Americans, or where African Americans lived, and really opening it up to anyone who either lived or engaged in care in these areas. We worked with HIPS as well as Casa Ruby to do recruitment with some support from HealthHIV. And, oops, I'm going the wrong way. And we did a great deal of promotion, which is shown here. Data collection, we did a 20-minute introductory interview to get folks into the study. And at that time, we gave them an incentive as well as a mobile phone. The mobile phone wasn't just for making calls or anything. Instead, it was set up to collect pictures that folks took with the phone in response to questions that we sent them once a day over a 5-day period. After that 5-day period in which folks answered questions with their phone, we met up to talk about the pictures that they took, which was done in a way that was quite encrypted, so no one's data could be leaked out to the public. During the interview, the follow-up interview, we talked about their photographs, and we also did we had a semi-structured interview instrument to help guide the discussion. Those lasted on average about 1 to 2 hours. This resulted in a very intensive data analysis period and helped us find some rich information about our participants and their lived experience. We ended up working with about 36 folks. We had originally gone in trying to recruit 12. So we were, it was an embarrassment of riches in terms of engagement. We had 25 biological men in the study and 11 trans women who were broken down somewhat equally among age groups. There was a great deal of poverty among the folks who were in the study. That did not really align with their educational attainment, which tended to be much higher than what you might anticipate, but that also reflected participating in educational programs through prison or jail programs. The study really came out and showed that Folks' approaches to health were informed by their formative experiences, which you would expect. The one piece that is probably a little bit unexpected on this list is engagement in gang membership, which created a sense of family for a lot of the folks who were in the study, and it also provided their initial employment. It also informed something that we called the BMSM Intersectional Identity Health Index. As I noted earlier, we were very interested at first only in sexual harm reduction to prevent HIV infection and transmission, but it really became part and parcel to an overall approach to self-care and also in creating social networks. There was a great deal of emphasis when people talked about their lives, about creating family where they didn't have any, finding a mentor to show their way, and also a great deal of emphasis upon physical safety, not just sexual safety, but protecting oneself from harm and others as well. There also was an emphasis on getting yourself housing, taking your medication if you're HIV positive, and developing yourself. There also was a great deal of medical distrust, particularly of biomedical approaches to HIV prevention. This led to something called the BMSM Intersectional Identity Over the Life Course Framework, which, as you can see here, the BMSM Intersectional Identity Health Index domains was a great part. I don't think I have time to go into this in great detail, just to say that there was a great deal of intersection and interaction between one's individual as well as their interpersonal community and greater engagements. And that really informed how they saw themselves and how they felt others saw them. And really impacted their approach to health and ultimately their practice in sexual harm reduction. This all existed over, if you will, the social geography that informed their lives. And social geography is that lived environment in which BMSM create and communicate and maintain their social networks, their identity. It also was something that was literal, where when you went outside and you engaged with everyone, but also it could be part of your imagination and how you remembered the world in which you lived in the past. Now, it also could be in person and online, and gentrification really disrupted and also became a source of environmental insult on persons' identities, particularly since it disaggregated these spaces, leaving BMSM with little access to information and support, and really undermined their health outcomes. So even though gentrification is technically defined as investment, participants defined it, and without exception, they defined it as white money and people invading historically Black and BMSM spaces. A lot of folks talked about the destruction of their childhood and also their first understanding and acceptance of themselves as BMSM. And it was these stories that they share were quite traumatizing for themselves and also to hear them as well. They felt particularly like strangers in their own lands, if you will, because they were treated as unwelcome in areas that had been gentrified by the new residents. And someone described it as a Category 5 tornado coming through and just wiping everything away from you. And someone said, you know, you wake up like, what am I supposed to do? Gentrification is taking over. This used to be Chocolate City, and it's far from that now. The other thing, my participants, a lot of them were very highly engaged in sex work and the stroll. And even those who weren't really in Washington, D.C. were focused on the stroll. The stroll is a workplace where folks can engage and find sex work as well as survival sex. But it was also something of an LGBTQIA coming out oasis and a hotspot, and was quite integrated. It also created that sense of community and that sense of congregation and girl chatter. And it was also a place where folks learned how to live as BMSM in the world, whether they learned how to be trans women and how to present themselves. It also was a place to express joy and engagement, and also a sense of protection from non-BMSM persons. So If this is a map of the stroll in the 1970s. If you look to the left here, this is a map of the percent Black population in 1970. And you can see that the stroll went right through the middle where a lot of LGBTQI plus recreational spaces and organizations were located. It's here in the middle in a large blue line, a swath going right through the city. The red is where the stroll is today, and the stroll is quite dissipated and spread throughout the city. And it's also segregated. These different red hotspots are where different BMSM might go to work, whether they're trans women, whether they are boys who consider themselves more feminine, or just different like that. And I just included up here at the top for consistency, HIPS and Casa Ruby, where they are located on the map. And why that is important is because HIPS tends to cater to older BMSM, while Casa Ruby is catering to younger persons. So in addition to this dissipation of a centralized stroll, you have a dissipation and disaggregation of service providers in the city because of gentrification. As they're being dislocated, you also are having a dislocation of age groups across the population. I just talked about this a great deal, and I wanted to point out the pictures to the left. You can see someone is taking a picture of the plate glass window of HIPS, and one of the big concerns was that HIPS was going to have to move because across the street, where there used to be a shopping center that was kind of low cost for the neighborhood, there is now a very fancy and intimidating high-rise building that's very high-end. Other folks took pictures of service providers that were being slated for demolition in Southeast. The other thing that came up was this bifurcation of service delivery in Washington, D.C. for younger and older BMSM had created some tensions between older and younger BMSM as their social networks and bridging through centralized locations became, there was less opportunity for that. This is just a note here, just sort of speaking to everything I had talked about before. The other aspect of gentrification is creating greater isolation, particularly for older BMSM who may also be more infirm due to just age as well as past medical issues. And because of that sort of issue with younger BMSM and having less robust relationships, leaving them more open to abuse, whether it's by younger BMSM or other groups. So discussion, lost shared space and history, and a lack of engagement across age groups, really undermining engagement in healthcare and really impacting and augmenting and positively modifying the impact of stigma on the population as they try to engage and survive. So thank you very much today.
Thank you so much, Dr. Compte. Really appreciate that. We are just about out of time. However, I did want to ask Dr. Wyatt a question related to your work. Some individuals had asked whether or not PrEP was offered or people were taking PrEP during that time, but I'm wondering also to the U equals U movement. Was that also in play at that time that you were doing your work?
No, U equals U was not, but PrEP was increasingly being offered to individuals who were positive, and there were many who were on PrEP but still stayed in our intervention to learn about condom use. Because there still isn't a huge consensus amongst African Americans who are infected with HIV or at risk about some of the new medications, I think it's important for us to create a base for them so that no matter what happens, what they like, what they don't, if they want to try something new, or if they've been recommended to get off of everything, they still can protect themselves. And that is the reason why I think that these kinds of interventions are extremely important. New things will come and many will stay, some will go, but I think that condoms have been around a long time, and we were really surprised and delighted to see that when we framed how to take care of each other if you really care about each other with condom use, it was much better received. There was another question about interpersonal violence, which I'm glad was asked, because this is an issue that many people don't ask about when they're screening individuals in an intervention, particularly if they are in a relationship. We screened couples out if they had any kind of interpersonally violent relationship within the last year. And if anything happened that cited the violence again, they were referred but not allowed to come back into the intervention until those kinds of behaviors had lapsed at least 6 to 9 months currently. So we really discourage couples to get involved if they had had a current history, because we wouldn't have known what in the intervention might have triggered another incident. And we certainly didn't want that to happen. We were teaching couples to trust, to communicate with each other, and the way in which they can really demonstrate their love and commitment is to be kind, to be loving, and of course to protect themselves. And we wanted to make sure that we followed through on that with all regards to relationships.
Great. Thank you so much. And I know that we're out of time, and I want to encourage folks that if you do have additional questions for our panelists today, to please find them in the app and shoot an email to them. I'm sure they would be very happy to answer any of your questions that you have. Dr. Wyatt, Dr. Turan, Dr. Compte, thank you so very much for participating today, and for all of our participants out there. Enjoy the rest of the conference.
Thank you.
Thank you. It was a pleasure. Bye-bye.